Hello, everyone, and welcome. I'm Christina Hawes, Community Engagement Coordinator for the Community Outreach and Engagement Office of Wilmot Cancer Institute. I'd like to welcome you to today's webinar, Wilmot Achieved NCI Designation. What does this mean for our community? This webinar is a part of our Community Conversations on Cancer series, an educational series designed to inform, educate, and disseminate best practices in cancer research, clinical care, and community engagement. It is sponsored by the Office of Community Outreach and Engagement, CERTEC, and the Community Cancer Action Council, or CCAC. This live event has been approved for 1 AMA PRA Category 1 credit, 1 CNE credit for nurses, and 1 contact hour for social workers. If you'd like to receive credit for attending, make sure to fill out the post survey. The link was provided in your registration confirmation and will be sent in a follow-up email. Our presentation today will be followed by a facilitated Q&A session. Throughout the presentation, please feel free to enter any questions in the Q&A box located at the bottom of your screen. Now, before I introduce our experts, I have a short message from Dr. Jonathan Friedberg, Director of Wilmot Cancer Institute. Dr. Friedberg was unable to make today's webinar due to travel, but he wanted an opportunity to cue up our discussion. So let me share a video with a few words from Dr. Friedberg.
I'm Jonathan Friedberg, Director of the Wilmot Cancer Institute at the University of Rochester. I'm thrilled to share the news that Wilmot has achieved an extraordinary recognition that puts us in the top 4% of all cancer centers in the United States. The National Cancer Institute has designated Wilmot as one of the elite cancer centers in the nation. Of the estimated 1,500 cancer centers in the U.S., only 73 have been through a rigorous, years-long process that ends with this designation, signifying transformative research, superior expertise, and world-class patient care. So why does this matter? Wilmot serves more than 3 million people across a broad and diverse 27-county area, and studies suggest that patients treated at NCI-designated centers have better outcomes, often due to participation in clinical trials. We have over 200 active clinical trials, giving patients access to promising new therapies, often before they are available elsewhere. This number will continue to grow, as many trials are only available at cancer centers with this designation. As part of this designation, the NCI has awarded us a $10 million grant to support our research programs, technology, community outreach efforts, and education and training for the next generation of cancer doctors and scientists. Knowing that NCI designation was a major focus, some of the world's most brilliant and talented researchers and clinicians have chosen to make Wilmot their home. Now that we have received designation, our recruitment efforts will only accelerate. Clinicians and trainees will seek us out to join one of the country's top cancer centers. NCI cancer centers, especially academic medical centers like the University of Rochester, are focused on team science and a culture of working cooperatively. We've designed systems to ensure that teamwork is a priority among our scientists and with input from the community. An example of collaboration is around cancer aging research. Our population is older than state and national averages, and we have researchers working on all aspects of this, from cellular keys to prevention of cancer, to our pioneering specialized treatment of older adults and leadership in national circles on this topic. We are the largest and busiest cancer center in New York State outside of New York City, and we're optimistic about the future. We anticipate significant growth and look forward to creating a new research program to develop cutting-edge novel treatments and study their impact in the laboratory and the clinic. Our aim at Wilmot has always been to ensure that no one in our geographic area needs to travel to receive the highest level of care for both common and rare cancers. And with this designation, we will become a national destination for world-class care. Achieving NCI designation was a 10-year effort and a personal goal of mine since I became director. I want to thank the community and the dedication and commitment of everyone involved in this Herculean effort. The future of cancer research and care at Wilmot is brighter than ever.
So a special thank you to Dr. Friedberg, who, even though he wasn't able to be here, was able to share his thoughts with us. So now that we're ready to go, let me introduce our experts. Dr. Charles Kamen is the Associate Director of the Office of Community Outreach and Engagement at Wilmot Cancer Institute. He's also an Associate Professor in the Department of Surgery, Cancer Control, the Center for Community Health and Prevention, and the Department of Psychiatry at URMC. He received his bachelor's degree from Notre Dame and both his master's degree and doctorate from the University of Georgia. Dr. Kamen is a renowned researcher, focusing on behavioral medicine, relationship-based interventions, and health equity research, with an emphasis on cancer-related health disparities impacting sexual and gender minorities. Dr. Francisco Cartujano Barrera is the Assistant Director of the Office of Community Outreach and Engagement at Wilmot Cancer Institute and the Director of the Wilmot Cancer Institute Tobacco Cessation Program. He's also an Assistant Professor in the Department of Public Health Sciences, the Cancer Center, and the Center for Community Health and Prevention at URMC. Dr. Cartujano conducts community-based participatory research for cancer prevention and control among underrepresented minorities. He's focused on the development and implementation of culturally and linguistically appropriate mobile interventions among Latinos. And finally, Mr. Jeffrey Freeman is a program manager of health coalitions at Common Ground Health. He supports the African American and Latino health coalitions and the New American Advisory Group to improve the health status of residents in the 9-county Finger Lakes region. Mr. Freeman also serves as the co-chair of the Community Cancer Action Council. He gives back to the community, volunteering on several projects geared toward youth leadership and education in the Rochester community. So welcome to all of our speakers, and I will now hand it over to Dr. Kamen.
Thank you so much, Christina. It is great to be here, especially to talk about this specific topic, which, as you heard from Dr. Friedberg's overview, has been a long time coming, but we're very excited that we have achieved NCI designation. And we want to spend a little bit of time talking with all of you about what this actually means for us internally at the Cancer Center and also for you all in the community. We're going to break this up so that I'll talk about our journey to get to designation and what the designation means just in general. Paco Cartujano will talk about what we're doing now within the center and what the future will look like in terms of our work with the community. And Jeff Freeman will talk about how the community was involved in us getting designation and community perspectives on the designation. So you heard from Dr. Friedberg some of the overview of what an NCI designation actually is. So hopefully it's pretty clear that this is a major recognition of our world-class expertise as a cancer center in cutting-edge cancer treatment, as well as cancer research. Before we were designated, there were 72 NCI designated cancer centers, so we are very proud to be the 73rd. And you can see on this map each of the cancer centers that are designated and the catchment area that they serve. This is the geographic region from which that cancer center draws its patients to treat for cancer. The goal of the National Cancer Institute is to cover this entire map with cancer centers so that anybody at any place in the United States could access high quality cancer care and cancer research at an NCI designated cancer center. You can see our catchment area up here. And before we were designated, the entire upstate New York region outside of the Buffalo area was not covered by an NCI designated cancer center, which shows how important it was that we received this designation so we can better serve this specific community. How do you achieve NCI designation? It's a multi-step, lengthy process, as was alluded to earlier. But it really starts with the science. You have to have a really strong spine of research to even begin to think about applying for NCI designation. So our journey began with us creating strong research programs in basic science. That's lab science, so looking at cells or DNA or mouse models of cancer, as well as population science. That's science that works with humans, whether that's epidemiology, looking at trends in cancer incidence and mortality, or behavioral treatments for cancer like yoga or Tai Chi for cancer survivors. We had to put together 3 strong research programs covering those topics. Around that hub of science, we had to create offices for clinical trials. You heard from the video that enrolling patients into clinical trials for cutting-edge cancer treatment is one of the main goals of an NCI-designated cancer center. We have an Office of Cancer Research Training and Education that is to train the next generation of cancer researchers within our center, and an Office of Community Outreach and Engagement, which is the office in which I and Dr. Cartagena sit. The NCI designated centers also have a set of shared resources that have to be developed. These are communal laboratories or tools that any member working within the cancer center can access. So for example, if you are looking at genetic risk factors for cancer, you could use a shared resource within the cancer center to help you to analyze a DNA sample to see if that genetic risk marker was present. That means everybody can have access to the same high quality tools, whatever kinds of science they're doing. As I mentioned earlier, to get designation, you have to define your cancer center's catchment area. Our catchment area, as you've no doubt heard, is 27 counties in upstate New York. You have to gather an external advisory board. This is a group of scientists who help to vet your readiness to even apply for NCI designation. And this is a requirement of the National Cancer Institute. Before you can even submit your grant to become designated, you have to have these external advisory board scientists sign off that you are ready to apply. Once that's done, you write the giant grant. And you can see a picture here of our director, Dr. Friedberg, with a 1,400-page grant that we constructed to submit to the National Cancer Institute. Once the grant is submitted, then the National Cancer Institute sends site visitors to come to your center to review you in person. So every component, all the scientific programs and offices and shared resources do a presentation about what they do within the center, and the reviewers decide whether or not you are ready for designation based on both the written grant and the site visit presentations. That is a lot of work. And so you might be wondering, why would anybody go through that entire process? Well, it's important for several reasons. First, as Dr. Friedberg said in the video, this is really an important recognition of our excellence in clinical care and research. We are truly in the top 4% of all cancer centers in the country. And that is an amazing testament to how much work is happening right here in Rochester to advance cures of cancer. It is a grant, so it does provide funding for center programs, but that's not really the main goal. $10 million sounds like a lot, but it doesn't stretch all that far when you cover all the different programs and offices the center includes. Truly getting the recognition for all of the centered work that we're doing is, I think, the most important component of this designation. It also, as you heard, allows us to attract new scientists and clinicians who are excited to work at an NCI-designated cancer center. And so we can bring on board more talent to do more cutting-edge science and provide more high-quality treatment to patients. And relevant to this group, it will allow us to partner new ways with healthcare organizations across the catchment area, as well as with those of you in the community. So we're really excited about that part. I want to take just a couple minutes and tell you how we got to the point of getting designation, because you heard it was a 10-year journey, but actually the story of our designation stretches way further back even than that. So way back in 1971, Richard Nixon signed into law the National Cancer Act. That allowed the National Cancer Institute to create the Cancer Centers Program, which was the program that funded the NCI-designated cancer centers. This is a complete side note, but there's a lot of debate about which cancer center in the country was the very first cancer center. There are 3 contenders. There's Memorial Sloan Kettering down in New York City. There's MD Anderson in Texas. And then right next door, Roswell Park in Buffalo has been in existence since the 1800s, and so is definitely one of the oldest cancer centers in the country. But designating those existing centers happened first, and then the National Cancer Institute allowed other centers to apply for designation under this Cancer Centers program. Our University of Rochester Cancer Center was chartered in 1974. In 1975, we applied for and received NCI designation. Over the next several decades, we conducted incredibly high impact research on cancer. And I think that's highlighted by the fact that when members of the American Society of Clinical Oncology were asked, what are the top 5 most important innovations in cancer research over the last 50 years? They named 2 innovations that had come out of the University of Rochester. So Rochester was seminally involved in creating the science that led to the HPV vaccine, which is an incredibly effective cancer prevention strategy for cervical and other cancers. And Gary Morrow and his colleagues here in the division where I sit, the Division of Supportive Care and Cancer, did pioneering work in anti-nausea and anti-vomiting therapies for patients undergoing chemotherapy. And back in the day, in the 70s and 80s, oftentimes people could not complete their chemotherapy treatments because the nausea and vomiting from cancer treatment was so bad. And so having effective anti-nausea and vomiting strategies allowed people to stay on treatment longer, complete their treatment, and ultimately have better results from their cancer. So really, I think that just shows 2 of the top 5 most important innovations in cancer science happened right here in Rochester. That shows how critical we were to the landscape of cancer in the country. Unfortunately, in 1999, we lost our cancer center designation. The site visitors came from NCI and felt that the university wasn't committed to cancer as a specific issue within the landscape of other issues it was dealing with. So we were not renewed with our designation in 99. But that kicked off a many-decade journey to regain the designation, starting in 2000 with renaming our center after James P. Wilmot, building a new, beautiful building you can see on Crittenden Boulevard. And then in 2013, our current director, Jonathan Friedberg, was named and made getting designation back the core of his directorship. We began to expand our presence across the catchment area with multiple hematology and oncology services. In 2016, we all signed on to a strategic plan to try to get designation back within 5 years. If you saw on the previous slide that whiteboard in the back with all the signatures, that was all of us signing on to say, yes, we're on board to get the designation. We convened our external advisory board in 2018. And then in 2021, we submitted our first designation application. And a lot had changed between 2018 and 2021, most notably COVID. The pandemic was in full effect. So the site visitors from NCI couldn't actually come in person to visit our center. And we had a site visit that was virtual. We presented virtually to the site visitors. And our score was good, but I think as a result of not coming in person to Rochester, we didn't score quite well enough to get funded at that time. And we're advised to resubmit a revised application. We did that in 2024. And at that point, people were able to come to the University of Rochester for the site visit. We did much better. Every single score got better. And in 2025, the designation was awarded. This is significant. It was 50 years from the chartering of the Cancer Center to the time when we submitted the application, and then 50 years from our initial designation back in 1975 to the new designation in 2025. So it was a long journey, but I think you'll see as we go through the other presentations, it's been very much worth it for those of us working in the Cancer Center, and I think will make it very worth it to continue working with you all in the community. I'm going to transition to my colleague, Paco Quattrojano, who will take it from here and tell you a little bit about what we're doing now in the center.
Thank you, Charles. I'm gonna start sharing my screen now. 1 second. So I'm gonna expand on some of the things that Charles has recently mentioned. The NCI designation is an award that supports the research infrastructure for cancer research to advance scientific goals and foster cancer programs that draw together investigators from different disciplines. And this is taken out of the NCI website. So what I'm going to expand on is the current research infrastructure at the Cancer Center. Charles mentioned that we have three comprehensive and robust programs, and I'm going to start highlighting them. The very first one is the Genetics, Epigenetics, and Metabolism program, and this is led by Dr. Darren Carpizo and Paola Bertino. By the time of the site visit, this was a program that had 29 scientific members and had a direct funding of $4.9 million. The next program is the Cancer Microenvironment Program. And this is, at the time of submission, this was led by Drs. Kims and Calby. And this is a program with 30 scientific members, and they had an annual funding of $5.1 million. This program has a new leader, Scott Gerber. And last but not least is the Cancer Prevention and Control Program. And this is a program led by Doctors Supriya Mohile and Karen Mostian. This is the program I'm part of. Charles is also part of this program. And this is a program that has 32 members, and we have an annual budget. We bring annually $10.7 million. This is complemented by the shared resources that we have at the Cancer Center. These are some of them. We have the biostatistics and bioinformatics shared resources, the human biophysiology, cytometry, imaging and radiation, genomics, biobank, and metabolomics. Metabolomics is the latest shared resource, and we're very proud that this was recently launched by the Cancer Center. And all of the scientific members of the Cancer Institute have access to these shared resources. We also have our amazing Office of Clinical Trials, and this is also taken out of the Clinical Trials Office here at our Cancer Center. Wilmot offers more than 200 clinical trials with new strategies for treatment, management of side effects, diagnosis, and prevention of cancer. And I think we have been working very closely with our Office of Clinical Trials, as some of you were involved, for example, in the development of this video, highlighting the importance for community members to participate in clinical trials and how this video is available in Spanish and American Sign Language. The Office of Community Outreach and Engagement has appointed different liaisons to all of these programs. We have Dr. Benjamin Frisch, who is the COE liaison for the Cancer Microenvironment Program. We have Dr. Isaac Harris, who is the COE liaison for the Genetics, Epigenetics, and Metabolism Program. We have Tracy, who is Dr. Tracy McInerney, who is the COE liaison for the shared resources. We have Dr. Scott McIntosh, who is the COE liaison for the Cancer Prevention and Control Program. And we have Dr. Anna Weiss, who is the COE liaison for the Office of Clinical Trials. We meet monthly, and the purpose of the creation of these roles is to make sure that all of these programs are being responsive to the community needs. So we are trying to make sure that we're serving our catchment area and that everybody has access to these programs and resources. Another office of the Wilmot Cancer Institute is the Cancer Research Training and Education Coordination, and this is being led by Dr. Nicole Odell, Ruth O'Regan, and Carla Casulo. And recently, the appointment of a new assistant director, Dr. Brian Altman. So they ensure that trainees are receiving excellent training as part of their trajectory to become independent principal investigators. And our favorite component of the Cancer Center is the Office of Community Outreach and Engagement. And this is an office that was established by Dr. Ana Paula Cupertino, and who was appointed the founding associate director of this office. And recently, Charles took the leadership role, and now he is the associate director for this office. I have always been the assistant director, and I remain to be the assistant director for this office. And as some of you know, but it's good to recap, this is an office that has 4 aims. And this is what we are mandated to do as part of the NCI designation. The first thing is to define who are we serving, what is our catchment area. And this is something that we define by the number of patients treated at the Cancer Center and the patients who were getting enrolled into clinical trials. So 97% of the patients who were treated at Wilmot come from this area, and 94% of all enrollments into clinical trials also come from this area. And this area compromises 27 counties in central and western New York. We have approximately 3 million residents living in these 27 counties. 29% of the population in this catchment area reside in rural areas. And as I said, this was informed by number of patients and accruals into clinical trials. This catchment area has also some key characteristics. For example, we have racial and ethnic diversity in urban areas. We have aging and low literacy in rural areas. We also have a high overall deprivation index. And as you probably know, Rochester has the highest deaf community per capita. And this catchment area presents a lot of challenges. One of them is being cancer incidence and mortality, which compared to both New York State and the US as a whole has been remained higher for the past 20 years. And some of the work that our office, Community Outreach and Engagement, has done is to define what are the priorities for the Cancer Center. So in partnership with community members and some of the people who are in this call, who we're very grateful for your input, we have determined that the Cancer Center is set to have a high impact in these three priorities: tobacco-related cancer, pancreatic and hematobiliary cancer, and hematologic malignancies. And definitely the highlight of our Office of Community Outreach and Engagement is the Wilmot Community Cancer Action Council. And if you are not part of this group or you're interested in joining us, please feel free to contact us. And this is a very active council that has really embedded itself throughout the catchment area. And they have some leadership positions, making sure that all the operations at the Cancer Center have some sort of community input. One of the highlights of the work of the Community Cancer Action Council is their involvement in defining who gets COE funding, who are the scientists who receive COE funding. So we have implemented a pilot program for the past couple of years. As you can see in this slide, Nikisha, Karen, Jeffrey, and Edgar have served as reviewers, and they have helped us identify what are the projects that are more responsive to community needs and who have a higher impact of resulting in future external funding. So some of the investigators who have received this funding come from all the three research programs that we currently have. And they have also secured additional funding, and they have also published the results in cancer-related scientific journals. This is also complemented by the community advisory boards that our office has convened. We have at least 6 of them. We have the Addressing Hematologic Malignancies Community Advisory Board, the Adolescents and Young Adults, the Faith in Community, Geriatric Oncology, Latinos contra el Cáncer, Latino Youth, Kick Vaping, and Sexual and Gender Minority Survivors and Caregivers. I particularly work very closely with the Latinos contra el Cáncer Community Advisory Board, and I can attest to the power of these community partnerships. They have helped me secure a recently funded R01 by the National Institute of Minority Health and Health Disparities to study the impact of physical activity in smoking cessation treatment among Latinos. So if anybody in this call is also interested in joining one of these community advisory boards, please feel free to reach out, and we're more than happy to connect you with one of these boards. One of the other mandates of our office is the outreach. So by the time of the site visit, we had done over 700 targeted events, reaching over 21,000 community members through our catchment area. And one of the highlights of our outreach is the Wilmot Tobacco Cessation Program, which is a program that was funded in December of 2020. And if you don't know about this program, please reach out, because this is an amazing program that we're offering throughout our catchment area at no cost. We are offering counseling via text messages, and this is available in English and Spanish. And we're also providing up to 10 weeks of nicotine replacement therapies at no cost. And again, this is available at no cost to all individuals throughout our catchment area. And I'm happy to report that this is a program that since inception has reached and treated 689 community members who currently smoke. And we're also reaching a very diverse sample of patients. So this is reflected in the distribution of age, gender, ethnicity, race, and also where these patients are living. For example, we know that the median age is 55 years old, 60% of them are female, 9% of them self-identified as Hispanic or Latino. We know that 13% of them self-identified as Black or African American, and 25% of them live in rural counties. And we're very proud to report that people who enrolled in this program, 4 out of 10 are currently quitting smoking. So our cessation rate at month 3 is 43.3%. One of the other things that our office does and how this is going to impact our catchment area now that we have achieved NCI designation is that our ability to sit and work collaboratively with other cancer centers. For example, we're now part of the New York State Cancer Center Policy Work Group, this is a work group with all the other NCI designated cancer centers in New York State. And given all the expertise that we have on vaping, and especially so the impact of social media and marketing in social media of electronic cigarettes on future vaping, this is something that we're currently leading in partnership with all these other cancer centers. So we recently submitted a letter to the New York delegation in support of the Kids Online Safety Act, which is an act that is trying to prevent and regulate the access that minors have in terms of social media and their exposure to electronic cigarettes. And just recapping on one of the slides that Charles previously presented, the NCI designation is important because one, it recognizes excellence in clinical care and research. It provides some funding for cancer programs. It allows us to attract new scientists and clinicians, and it's going to allow us to partner in new ways with other healthcare organizations and with the community. And yes, COE is something that the Cancer Center is willing to continue supporting. And take this from the words of Dr. Jonathan Friedberg. And this is a letter, an interview that he gave to the Cancer Letter, in where he said, "We are investing in COE activities, including a large office with numerous people and including staff that sit in some of the rural counties to make sure we're educating and engaging those individuals. I do not see that stopping, and I think that investment has really only helped us." So with that, I'm going to hand now the room for Jeffrey. Thank you. Muchas gracias.
Right. Thank you. Thank you for that wonderful introduction. A lot of information has been shared thus far. I don't have any slides, but I do have a script that I'm going to read off just so I don't miss anything. So, as was mentioned earlier, I am a co-chair of the Community Cancer Action Council, better known as CCAC. I do get to co-chair it with Elisa De Jesus, who was unable to join us today because of prior commitments. Just a quick description of the CCAC itself. Basically, it's a community-led group of individuals. I think we have about 50 active members, but I'm sure there's many, many more who are involved across our 27 county region. But our purpose is of course, to ensure that community input is integrated across Wilmot's priorities and initiatives. And we do meet monthly over Zoom, and we meet to share updates as well as receive new information from Wilmot researchers on initiatives that they may be undergoing, as well as share information from our existing projects. Over the past 5 years, and coincidentally is right around the same time as the pandemic, it really proved the importance of having a community action council around cancer, because people obviously couldn't go to the doctor as much as they like. So there was some we lost some ground in sort of the testing and sort of the screenings, and as you can imagine, with not being able to go to the doctor. So it was really important to have a group of individuals who would do the outreach along with Wilmot in the communities. And these individuals represented organizations who are pretty much already doing the work. As you can see in my background, I work with Common Ground Health. Um, prior to Even prior to the pandemic, we did a research project which was eye-opening for me. We focused priorly on chronic illnesses such as um, heart, blood pressure, and diabetes, which is of course still important. But when we did just a quick research around what are the main reasons why people are dying before the age of 75, we saw that cancer was the leading cause of death before the age of 75 across the board under for all of race and ethnicities, for all socioeconomic groups as well. So that really was an eye opener for me, because to me, cancer doesn't have a disparity there. Of course, there's disparity around access to care and even education around the importance of of um, the importance of cancer research. And so that's when the opportunity opened up to work with the Cancer Community Action Council, I jumped at the opportunity. Over the past 5 years, we kind of used a multi-pronged approach to identify the areas that we wanted to have an effect in. We in really 4 areas. We have our community-driven cancer research group, or I should say work group, and they focus on having forums and sharing information within the community about clinical trials and the importance behind clinical trials. We have a survivorship work group, which created a wonderful resource map that helps people identify where they can resources close to where they live. Really should take a look at it. It's on the website for Wilmot. Prevention was another work group who worked closely with the churches, and I think you've seen a little bit of that in the previous presentation. We partnered with churches in holding cancer symposiums, just providing information and connecting the community with Wilmot researchers as well. And lastly, we had a rural access to care, which was very important. They really tried, really making efforts in the counties and areas that are not so close to immediate services. I guess you would say it was kind of stressing the importance of telehealth hubs and how people can, even though you're not be an hour drive for you to come into Wilmot, there's no need for you to put off any care because there's telehealth available, and those efforts are ongoing, as you can imagine. Other than our work groups, the CCAC has helped Wilmot. We do participate in the 5-year strategic plan, making sure that there's community input in what is written. And so that's an honor as well. And I think lastly, I would mention is that we get to host or share in the hosting of the annual retreat in October, along with the Office of Community Outreach and Engagement and research as well. We get to share perspectives from anyone. We obtain perspectives from community members interested in participating in the CCAC, as well as receive information from the latest research discoveries from our esteemed researchers over at Wilmot. So again, we're open to receive new members. We do meet monthly, as I mentioned, over Zoom. And I think if you stop in for a visit, you'll really be impressed if you haven't had the opportunity as well. And hopefully you'll stay a while. Thanks for your time. I'll hand it back to Christina.
Thank you, Jeff, Charles, and Francisco for this wonderful presentation. There was so much information in there, and I know that we already have a bunch of questions in the Q&A, but just for anyone that did not get a chance to yet, if you have a question, please feel free to put it into the Q&A box. You don't want your name attached, that's fine. You can put it in as being anonymous, and we're happy to answer any questions that you have for us. So let's get started. So our first question, which I'm not sure if we'll be able to answer, but let's put it out there. So looking at the NCI coverage map, Northern New York is not covered by an NCI center. So where do those residents go for care? And is there any thought to expanding Wilmot to perhaps cover that area? Great question.
A great question. I can start, and then I'd love if anybody else has any thoughts about this. So yes, when we define the catchment area, it was very thoughtfully done by looking at data regarding where patients come to receive care and where we're able to recruit patients for clinical trials, as Paco showed. And really that 27 county region was the bulk. 97% of the patients we serve come from those counties, and we cover all of the counties with clinical care and with research as well. We do see patients from other counties, though. We see patients from Albany, we see patients from Watertown up to the north of the catchment area. And so while we're still right now focused on making sure the 27 counties we've currently claimed as a catchment area are well served by our clinical care, our research, and our community outreach, I think there's definitely a chance to expand. And I don't think I'm violating anything by saying that that was indicated to us when we had the site visit, that there's a possibility, since no one is up in those northern counties, that Rochester could expand into that region to make sure the Catskills, Hamilton County, all of those northernmost counties still have access to high quality cancer care.
Thank you. That was more of an answer than I expected. I'm not sure. It was what I was kind of expecting. So I'm glad that sounds wonderful.
Yeah.
They do
Just so
need
everybody,
access.
yeah, just so everybody knows, when we decided on the catchment area, there was a time and a process where we took and added counties and then took counties away and just saw how that changed the map of where we were serving patients. So we definitely considered a lot of those northern counties in the formulation of the catchment area.
And
So
if I
just
may-
because oh, sorry, Paco, go ahead.
I was just gonna say, just to add something really quickly. So this is a dynamic process. So we're always gonna be monitoring where the patients are coming from and where the enrollments in clinical trials are coming from. And now that we have the NCI designation, there's a possibility that we're gonna be attracting more patients from those areas. So stay tuned, because who knows what's gonna happen next.
Leave it with a cliffhanger. I like it. Okay, I think actually, Paco, that this one is for you. So how do the COE liaisons make sure research programs are responsive to community? Do you have examples?
Yes, so this is also an ongoing process. One of the things that we're trying to do at the moment is to identify all the investigators from all these research programs and kind of like what grants they are submitting, with the idea that once we identified a researcher who has a research idea that may benefit from community input, to make sure we're making a connection from that with that investigator and a community member. So yes, we have our monthly meetings, but this is an ongoing process and always trying to make our research more responsive to community needs. This is a community conversation on cancer, and we're always looking for speakers. So this is also something we work very closely with the COE liaisons. We make sure to advertise this series to them, and if there's an investigator from those programs who is interested in presenting their latest research with the community members, this is the perfect venue for that. So yes, lots of opportunities there.
Thank you.
And I would take the opportunity to add that the COE liaisons also meet with what we call our steering committee of the CCAC once a month, and they pull ideas as well, or we gather ideas as well from the CCAC steering committee, or people who chair the different work groups that I mentioned.
That is a perfect segue to our next question, Jeff, which is for you. Who can join the CCAC and how?
Who can join the CCAC and how? Oh, well, I think you're looking at her. She's the contact person, but certainly let Christina know through the email that you may have received here that you want to be involved in CCAC, and she will add your name to the list and invite you to our next meeting, and we will give you a warm welcome as well.
Yes, and someone who's I've sat on the CCAC for years, and let me tell you, Jeff is a fantastic chair. They're always really engaging the meetings. So if you want to stop in, you can contact us and we'll set you up with that.
Yeah,
Okay.
we try to have a little fun at the end and celebrate each other.
We do. And I would like to mention too, because Jeff brought up our lovely annual retreat. So if anyone's interested in attending that, send me an email and I will make sure that you're on the list to get the invite for that event. Okay, so let's move on to the next. Oh, sorry, go ahead.
Just one additional comment about that in terms of who can join. Anyone's able to join, people inside the U of R and in the community. We especially want community to be represented on the CCAC. Obviously, it's a Community Cancer Action Council. So if you know people living in community who'd like to contribute their perspectives to Wilmot, please let them know to join. And especially if they're in a part of the county or a county that's outside of the Monroe Finger Lakes area, we'd really love to hear their perspectives. So get the word out.
And we are all about collaboration. So anyone that's coming in, even if you're not working within cancer, if you're a cancer survivor or a caregiver, we would love to have you because you find out everything else that other organizations are doing at the time throughout our region as well. So that's enough of a plug for CCAC, although we might throw in a few more as we continue on. But our next question, which Paco, I think this one is for you too. Does your doctor have to enroll you in the tobacco program? And is it a part of your health record?
So there are many ways to get enrolled into our tobacco cessation program. You can self-enroll, meaning if you smoke and you want to receive treatment, is as easy as just completing a contact form, and then we're going to reach out to you. Or you can also self-enroll through other methods like just texting us. So that's one venue. But the other thing, we're always looking for partnerships. So if you want to talk to your provider about this program, and then your provider is interested in working with us to make referrals, we're more than happy to take them. So as long as they live in our catchment area, we're happy to take any patients who smoke and enroll them into this program. So it is not necessarily part of the electronic healthcare record in terms of we do not say, oh, this person received treatment. But for example, with our internal electronic medical record, we do get referrals from providers. So also, if you're receiving treatment, any type of treatment here at the University of Rochester Strong Memorial, you can just ask your provider, and he should know how to make a referral to us. So, yeah.
So just to clarify, this does not go through your insurance to be free. It's just a free program.
Correct.
Thank you. Okay, our next question. So this will be open to Charles, Paco, whomever can answer this one. What additional or special RFAs, and for those that aren't in the know, it's requests for applications, so they're ways to get funding, are newly available because of the NCI designation? That's a great question.
That's a great question. Yeah, and being part of this designation group means you do have access to mechanisms for grant funding that you wouldn't have if you weren't part of the group. Most clearly, the National Cancer Institute itself sometimes releases additional grant opportunities for people working in NCI designated cancer centers. A few years ago, for example, they gave out a grant to do a population assessment of the catchment area to look at cancer health needs. And that would have been great to get because we'd love to know more about the needs of rural communities in our catchment area. So that kind of funding could go to support surveys or focus groups or town halls across the catchment area to look at cancer needs. There are also some foundations that allow only people at NCI designated cancer centers to apply for their foundation funding too.
Paco, anything to add, or are we good with that?
Just one other example. So at some point, there has been 3 times that NCI has been like, NCI designated cancer centers, I'm gonna be releasing money if you're interested in providing a smoking cessation treatment for cancer patients. And again, that was only limited for NCI designated cancer centers. Our hope is that one day in the near future, NCI is gonna release that call for applications again, and we are ready to respond to that call. So yes, it comes also with these special opportunities.
That's wonderful. So in addition to the money that they give you up front, it actually opens up a bunch of other pots of money that we're able to access. So that's wonderful. Okay, next question. We have quite a few left in here, guys, so we're gonna speed this along.
Okay,
Is your
great.
decision to focus on pancreatic and hepatobiliary cancers due to our region's high number of cases with these cancers? Does our region have higher cancer rate in those areas, higher than the national average?
It's a great question. These numbers shift a lot over time. From the most stable 5-year estimates we can see, the overall rate of pancreatic cancer isn't higher here than the rest of the country. The mortality rate is higher than the rest of the country. And part of the reason we focused on pancreatic cancer specifically, the disparities in pancreatic cancer mortality are really stark here. So Black community members diagnosed with pancreatic cancer die at a much higher rate than white community members in our catchment area. And that made us think that this was very important to focus on. Same thing with hepatobiliary cancer. Latino communities suffer from this cancer at much higher rates than white individuals do. And so that disparity is worth us focusing on in terms of research.
And Charlie, before we get off of that, can you just briefly say what hepatobiliary is?
Yes, liver cancer.
Thank you. I always, that one is always, it's difficult to pronounce and it's hard to remember exactly what it refers to. So to make sure we're all on the same page here, liver cancer is one of our focus. Okay. Jeff, I think you can answer this one. So what if you're an agency that doesn't necessarily work with cancer? Is there a place to still collaborate? Is there anything that you can talk about that in terms of CCAC?
I can't think of, well, if you're not in, I think the answer I would really say is I can't think of anyone who's not impacted by cancer. So even if your agency isn't directly working with cancer research or itself, certainly you can join the CCAC as an individual and pick up the information from there. And I'm sure you'll be able to see where your agency can lean in this fight against cancer.
And I'll add to that. One of our previous steering committee members actually came from Cornell Cooperative Extension, which does not directly focus on cancer. However, one of the things that Francisco constantly presents on is the collaboration between researchers and community organizations. And we actually have had Cornell go out to do food demonstrations with some of our researchers to talk about plant-based diets and just ways to make shifts in your diet to make your risk of getting cancer a little bit lower. So yes, we're open to everybody.
Yeah, and I think I would add to that, our lane is cancer, but that's a broad lane because it really does cover cancer prevention, like Christina said, with nutrition and physical activity and smoking cessation, as well as cancer screening, cancer treatment, cancer survivorship. So lots of organizations, I think, can have a mission that touches on that in one way or another.
Okay, so now we have a tough question. We'll come back to you, Joyce. But how is the current political landscape affecting research at the University of Rochester? And we all have the uncomfortable smile on our faces. So whomever wants to jump in on this one.
I can start, and then Paco and Jeff, feel free to chime in. Yeah, it's very uncertain times. The one thing that I can say is that cancer research itself is unlikely to be cut. Like cancer research is going to remain relatively intact, I think, as a focus area. The things that are likely to change are how we talk about some of the things that we do, especially within the community outreach and engagement space. As you saw from Dr. Friedberg's interview, the commitment to working with the community around cancer health is unchanged, but it is just a different world right now in terms of how we talk about equity and diversity initiatives, and how we ensure that all people in the catchment area have access to the same high quality cancer care and research, whatever terms we use to describe that effort. Do you want to add anything to that, Paco?
No.
That was, I think, the most political way that I could frame that. I will just say research is so important, and ensuring that we have cutting edge research that's funded to ensure that people can live long, healthy lives with cancer is is critical. It's critical to a cancer center. It's critical to the community. And so I encourage anybody who's concerned about what's happening in terms of restrictions on research to contact your Congress people. Let them know that you do believe that having an NCI designated center in your region is important, and that you want to see the research that we do continue unimpeded. That is really the best thing you can do.
Very good answer. So our next question. This is a wonderful question about some of our auxiliary sites. So our clinical trial is going to be available at the regional cancer sites like in Dansville or Geneva with this designation.
Oh, yeah, another excellent question. So yes, already that is the case at our Webster location. So we do have clinical trial capacity at Webster. And so anybody at the Village of Webster who goes to that center could enroll in one of our trials. We're definitely in discussions about how to expand to more locations. And, part of that is just making sure that we have things like the correct pharmacy to have the medications available and the correct nursing staff to run protocols. But I can definitely anticipate that we will have more sites with the same capacity Webster does to do clinical trials in the next couple of years.
Well, and with the clinical trials, I want to ask a question of you, Paco, because you had talked about joining the CCAC. So I think we talked about that a little bit and how people can do that. But you had talked about joining community advisory boards. So with that, I mean, are there limitations to who can join these groups? And then exactly how should they go about doing that?
Yeah, so as you probably noticed from the slides, these community advisory boards are either population or disease specific. For example, the Latinos Contra el Cancer is specific for Latinos. We have the one for hematologic malignancies, which is particularly targeting patients with hematologic malignancies. So reach out and we can see if there's a match with one of these community advisory boards. Yeah.
Okay, so then we'll put that, and we'll also put an email address in the follow-up email at the end of this. So we have 1 minute left. So in 10 seconds or less, what is the most important thing that people should be drawing from this in terms of NCI designation and how it's going to affect our community? So Charles, we'll start with you. 10, go.
Yeah, I mean, we want to hear from you, right? We got the designation because of our work with the community, and we want to keep that strong connection going. So any feedback you have for us about how we're doing, please come to the CCAC and give it to us.
Paco.
I'm going to say that the NCI designation brings a lot of hope in these uncertain times. And we are committed more than ever to work with the community to lessen the impact of cancer. So this is a great recognition and we're very thankful. And this is only because of the power of the partnerships we have developed with you, all of the community members in our catchment area.
And Jeff?
I think my message would be to the very few people who may not have been affected by cancer directly or personally, or someone they know, join in before it happens. Because as you mentioned, prevention is a big part of the work. It's not just about who has cancer. It's about avoiding, living a healthy lifestyle so you can avoid the cancer as well. So there's a lot to learn, and the help is certainly here.
Wonderful. So thank you to our presenters and to all of you for joining us today. Please be sure to fill out the survey following the webinar to make sure that we're providing content that you're interested in learning about. And those surveys must be completed to receive any continuing education credit. So the webinar has been recorded and an email with a link to the video. We will also send some email addresses out if you're interested in joining the CCAC or joining a community advisory board. Again, thank you for joining us, and we'll see you at our next community conversation on cancer on May 15th, focusing on myth busting in skin cancer. So everyone enjoy your weekend.
Right now.